Dear attendees and participants, F-Care Systems welcomes you all to this international online Rafaelo seminar in collaboration with our UK distributor, Modern Aesthetic Solutions. Most of you will know us, but for the newcomers, F-Care Systems is the developer and manufacturer of this revolutionary radio frequency solution for hemorrhoids called Rafaelo. We launched this technique 5 years ago in more than 46 countries around the world, and up to the present day, 15,000 Rafaelo cases have taken place. Enjoy this insightful seminar by our experts, and I leave the introduction of today's moderator to Mr. Adam Rubins from Modern Aesthetic Solutions. So Adam, the floor is yours.
Thank you, Michael. For those of you who I haven't met, I'm Adam Rubins and I run Modern Aesthetic Solutions, which is the UK distributor for Rafaelo and associated products. Many of you are existing Rafaelo practitioners looking to develop your knowledge of the treatment, but I also welcome the vast majority of you who are new to Rafaelo and looking to use this meeting as a training module to enable you to start offering Rafaelo locally to your patients. I'm delighted to introduce you to our moderator for this evening. He began his professional career at St Mark's Hospital and in 2005 moved to University College London Hospital, where he soon headed the colorectal department. He is clinical professor of surgery at Cleveland Lerner School of Medicine at Case Western Reserve University, and last year was appointed professor and chief of surgery and chair of digestive disease and surgery at the newly constructed and most prestigious Cleveland Clinic in London. He obviously has huge business cards. Having offered Rafaelo to his patients for the past 3 or 4 years, he's been very, very generous with his valuable time in sharing his knowledge of the treatment to dozens of our surgeons who he's assisted to train in the technique. His motto is, still enjoying learning about proctology even at this late stage. I give you Professor Richard Cohen.
Thank you very much, Adam. That was a very kind introduction. I'm delighted to see that we already have 140 participants online. I hope you're all going to enjoy tonight's session. We've got an excellent panel of very experienced surgeons in the treatment of proctology, in the field of proctology, and in particular in the use of Rafaelo. You can see, I can see Dr. Hartmut Schäfer, who's Associate Professor of Surgery at the University of Cologne in Germany. He's been a surgeon since 1989, specializing in proctology since 2006. He was head of the surgical endoscopy and proctology at the University of Cologne between 1997 and 2012. And since 2010 has been a partner in a private medical practice which treats patients with endoscopic diagnosis and proctology called the PAN Clinic in Cologne. We also have with us Dr. Carlo Vivaldi, who is head of the surgical endoscopy department at the Augustinian Hospital in Cologne and an expert in proctology. He was the co-founder of the END Darm private practice in Cologne in Germany. I hope I pronounced that correctly. And both Dr. Schäfer and Dr. Vivaldi have been using Rafaelo since 2015, and between them have carried out an extraordinary 600 Rafaelo cases and have spoken about their experience across the world, including Europe, the Middle East, and Russia. We have with us Dr. Piero Nastro, who is a laparoscopic colorectal surgeon here in the UK in Dartford and Gravesham NHS Trust, where he specialises in minimally invasive surgery, colorectal cancer surgery, and advanced proctology. And he's been doing Rafaelo since 2017 and has carried out over 100 procedures. He's posted an abstract on the use of Rafaelo on 50 patients, and he specialises in doing them as a day case procedure under local anaesthetic, which I'm sure you'll all be interested to hear about. That is the only setting in which he now offers treatment. Also on the team tonight, we have Mohammed Adama, who I've known for many years, who is one of the few true academic surgeons that I've come across for some time, and holds a position as one of our general surgical registrars at University College London, and has a simultaneous academic position at UCL, where he's doing work on biogenetic markers for epigenetic therapy in Crohn's disease, and biomarkers for diagnosis of colorectal cancer. He's going to be a star for the future, and I'm sure will be head of a department, a professor of surgery somewhere in London in a few years to come. So we've got a really good panel for you of folk who are very experienced in the treatment of patients with this procedure, and are going to give you the benefit of their experience tonight. And we're going to start with a presentation from Dr. Schaefer and Dr. Vivaldi, whom I'm going to hand over to now, and I look forward to hearing what they have to say. Over to you, gentlemen.
Thank you, Professor Cohen. It was a very nice introduction also for myself, and it's a pleasure for me that I can speak today to all of you. And we are still an increasing amount of people who are taking part in this very interesting meeting. But now we are going to start immediately with our presentation, where I take the part of showing you the technique of this Rafaelo procedure. And in the next part of this presentation, Dr. Schaefer will take over and tell you everything about the results of our trial. So I will start now with the technical details of this procedure, and I would like to see the next slide. So first of all, then we can go back, because first of all, it's interesting to explain the name of this procedure, because as you all know, it's called Rafaelo, and maybe someone is interested why this name is coming up, because when you take now from this complete name, radiofrequency ablation on a local anesthesia of hemorrhoids on a local anesthesia, you will just pick out some letters. In the end, you created a wonderful name. It's Rafaelo, which is quite interesting because this keeps them really in mind, and it's a nice name. I think just it's always good to have something what you have easy in mind. So now about the working principles of this technique, you can see here now on the left side of this picture, you see the generator itself, and the probe now, which is shown here, is a disposable catheter or needle, but in this case it's a very sharp catheter. We'll show later more detailed, and there is a tip which is non-isolated, only there happens something. Here is really the energy, and what happens immediately when you give energy with this generator, it will create some energies, radio frequency ablation, which causes the molecules in the hemorrhoidal tissue start frictioning, and in the end you will have develop a heat, and this causes for sure local agitation, some vaporization and dehydration of the tissue, and this in the end cause a collapse of this vessel. Here is it shown now on a vessel like a vein, but you see it's the same effect for sure in the hemorrhoids. So this is now to see the generator itself, and you can see here that you just use the Rafaelo procedure just with a tap. There are different possibilities for this, even like I said, also vein treatment. And as you can see here, very new now, there is a new trial which is going on in France to treat even fistulas with radiofrequency ablation, but this is another topic. Next. So just here a magnification of the screen, and you can see here several things. First of all, you can see the time which is going on during your procedure, and for sure the power with 25 watts. This is fixed and you cannot change it. And then there is for sure counting during you use the procedure, or during the use of the energy, the increasing joule, which you can see easily. Next. Well, this is just a movie now which shows you in a few seconds how it looks when the machine works. You see now the time goes by, and for sure increasing number of joules, as you can imagine. Interesting here on the left corner, you can see the status of the machine. It shows here on, and this is very interesting because always keep in mind it shows the status. When you start this machine first time, you might be a bit confused because when you try to switch it on, you have to press on this button, which shows in that moment off, because it shows the status off, and then you press on it, and then it will change to on. So in the beginning, it might be a bit confusing, but it is when you know it, it's logic. So next, please. So this is now the probe, which you can see very well in magnification. And interesting here is that it is, first of all, a very sharp needle. In the tip, you can see it's curved and very sharp. And when you can see this small plastic ring, this is the part from there and above to the tip. This is the isolated area, and here happens, like I showed before, the energy, and the rest of this completely probe is isolated, so there is no heat. Important here is, you will see it later, that this is a steel needle, so it's hard and it's not soft, as in comparison, for example, some of you might know the techniques of laser, and there you have a more soft probe. Here we have a steel needle, which is very a very good advantage for the procedure, as I can show you later. Next. This is a quite nice video here where you can see now how the needle works. You see already several stripes in this phantom gel where it's shown how the needle works, and you see these streaks of destruction inside this gel. And now during the use you can see immediately how in this gel the needle, because of the temperature, creates a kind of distraction in these small streaks, which you can see with this white, changing of this gel color into white. And this is exactly what happens inside the hemorrhoid. So you can see the diameter of the heat here is only 3 millimeters, which is excellent because you cannot harm deeper layers like the muscle or something else. And with this, you have for sure an absolute control. Now you can see very well. And even if you saw, when you take out the needle out of the injection point, you have even the possibility to give coagulation on the injection point. So you have almost no bleeding during the procedure. What you need for the procedure itself, you see here the instrumentarium, and what is interesting to know that the company provides a complete package where everything is inside already what you need for the procedure. For example, here, as you can see, is an anoscope always inside. They have two different sizes of anoscopes, which is a 23 millimeter and 18 millimeter. I would always recommend to take the bigger one because with 23 we have some space to work. With the 18 millimeter, for sure, some very sensitive patients or some females maybe might need the smaller one, but I would prefer to take the bigger one as possible. What else you need? For sure, you need the generator. This is clear. There are some cotton balls if you might need them, something, whatever you need to take, to suck some water, just cold water, because during the procedure and especially after the procedure, you have to give some cold water to cool the area down, which will avoid some edema or even can reduce maybe some bleeding. What else is interesting? You need a syringe, which is not difficult. Everybody has this for sure anyway. And a special needle, and this one we catch from our orthopedic colleagues because we try to find a needle which is not too hard, not too soft, but long enough for this procedure. And we found this one, this G20 brown needle, which is very nice to use for this technique. That's it, first of all. Yeah, next. Well, the local anesthesia is nothing special. We just use common lidocaine 1%, nothing else. For sure, there's possibility to take this somehow famous Klein solution. Some areas or countries might use them, but we are completely fine with lidocaine 1%. And we take always per pile about 3 to 6 milliliters for the injection. That's enough. Next. Well, the position for sure is something that is a bit individual. It depends on the surgeon, but most common, I guess, is a so-called gynecological position, which we use also because you have your both hands free and you don't need anything to spread the butt or whatever. So this is very nice for this technique. Now we go immediately inside the pictures. We have on our right side, we always try to have a live picture. On the left side is this cartoon. And first of all, we have to insert the anoscopes. I told you we try to use the 23 millimeter and put it inside the hemorrhoid. I already now have to apologize for the picture on the left side because it looks like the hemorrhoid is lower the dental line, which is for sure not regular like this, especially when you will see now in the pictures that we insert the needle and administer the local anesthesia. For sure, we do it above the dental line because we don't want to harm this, and everybody knows there are the nerves, and this we have to respect. So we will administer now deep below the hemorrhoid, the local anesthesia. It's like a pillow, what we put there in this submucosal layer. And this has two very interesting effects. First of all, it for sure makes the local, it reduces the local pain, but also it lifts up the hemorrhoid a bit so we can protect the deeper layers with this too. And when I do this regularly, I try to put it in a 30-degree angle inside the mucosa, but be careful, don't put it, don't administer it or inject it in the hemorrhoid, because what we really want to avoid is a so-called balloon effect. You don't have to blow up the hemorrhoid, because then as more liquid as is inside, as less functional will be the radiofrequency ablation, and you will need more energy. So because of this, try really to reach the right layer. You will see it, because when the hemorrhoid lifts a bit only, then you have the right layer and don't blow it up. After we put this now in the right position, we immediately should put in the probe. Be sure it's prepared, everything is connected, and don't start with connecting or preparing anything after you already administered the local anesthesia, because this is important. You don't want to see blood, or you don't want to cause bleeding. So take immediately the probe and put it in the same injection point where you already did the local. And as you can see here, we put it deep inside the hemorrhoid and try to reach the area where we think the feeding artery might be and or should be located. And then, and this is important, we lift up the complete hemorrhoid, and now we have the advantage of this hard needle probe, because we can lift the hemorrhoid itself in the center of the intestine, and can it have now a second possibility to separate it from the muscle layer. And then we will press the foot pedal and start the coagulation. The 24 watts I told you before is anyway fixed. And now we start the procedure. What you will see during the procedure is that the color of the tissue might change. It becomes sometimes gray, blue, sometimes it shrinks also a bit. And we use now during this procedure, depending for sure on the size of the hemorrhoid, around 1,000 to 2,000 joule per pile. When it's a smaller one, bigger ones can be up to 3,000, but at the very beginning, I will not recommend to do too much energy. Please don't overdo it, because it is in the beginning just a feeling and experience what you have to have, and you will not maybe always see a really, really good reaction like it's completely white. So you have to get a feeling for what you really need. So in the beginning, 1,000, 1,500 joule per pile is for sure enough to see results, because even if you don't see a necrotic reaction, you will have later a result, believe me. So after you treated now the hemorrhoid itself, you started, like I told you, in the base, and then we go in every part of the hemorrhoid step by step with like a fen, I always say, with this needle to reach all the areas, because remember, it is only 3 millimeter diameter, so you need some points. And after that, when you took it out and you coagulated the injection point, you might do some spots on the surface, because when it's a big pile, a 3 millimeter surface not reached by the energy. So be sure that even the surface is also coagulated. In between, you have to really be careful that the tip is always clean, because when there are some coagulation blood rests, it might reduce the effect of the therapy. And as I told you, always cooling down. The patient is awake. This is very important, because he can give you feedback every time when he tells you it becomes maybe too hot or it is uncomfortable, just cool it down. And I always say to the patient, a feeling like a seat heating is okay, but not more. If it increases more, don't be a hero. Tell me before, because when we avoid pain during procedure, we can avoid pain after procedure. So as I told you, cool down afterwards the area. Now we put here together some important take-home message for sure, because this is what I said: clean the probe every time if it's necessary, clean it of coagulum to have always a full functional probe. Start the procedure immediately after injection, what I told you, because if you are too slow, there can happen a blow-up effect. It can develop a hematoma, and as more as you wait with starting the procedure, you might have more problems. Lift the hemorrhoid when probe is inside. Very important, I told you, because you have to really avoid that something happens to the deeper layers. And cool down the treated area whenever it's necessary, or when the patient tells you it feels too hot. Important is, if you release the foot pedal, what I do sometimes, because I do it in waves, I don't give all the time the same energy. This makes the whole procedure very controllable. But at the moment when you release the pedal, there is zero energy. So every time it has to come up, it goes fast, but it has to come up to the really working heat. When the one pile is done, always turn down the shown energy to 0, that you have an exactly control how many joules you used for any pile. And in case, the rare case, you have really a bleeding during the procedure, what we really seldom saw, just remember for sure, first of all, don't panic, because when there's this small space, a lot of blood, you might be a bit in worry, but we are all surgeons, so we are not in worry. We have, this is what I recommend, prepared for any case, a suture close to you, and if there's really a bleeding, in worst case, just do that one stitch with a suture, just normal Vicryl or something like that, and then it will stop anyway immediately. I never had this situation, but just be prepared. Next. Well, we put down here some movies, which we go fast through because the movie itself for sure is too long. What you can see here is nice. First of all, you see this skin tag. You always have to tell the patient skin tag is not the aim of the treatment, that we want to remove the skin tag, but they have to understand it because 99% of the patients thinks the skin tag is the hemorrhoid. Just tell them we are going to treat the hemorrhoid itself. So that means now we just introduce here the hemorrhoid, the endoscope. You see very well now soon the dental line, which is here nicely marked by an anal small polyp in about 3 o'clock position. And then we see also very often a mucosal prolapse for sure. And these anoscopes are nice because they have an opening on the side, so the hemorrhoid will itself fall into the center, which is very good for the treatment. Now we put in the local anesthesia. And here for sure we have to respect the dental line and go shortly above over it into the tissue with the needle, which is shown soon. And for sure it's a needle and there's a pillow of vessels. When you take it out, there will be a bit blood. What you can see here nicely, I've already administered now around 3 to 5 milliliter, but the cytus, I mean the hemorrhoid itself, doesn't change anything. There is no blow-up effect, like I told you, very important. So we took out now the needle and the probe is already prepared and we do it immediately in the same position. And now it is what we told you before, we can use even the edge of the anoscope as like an angle and we can lift up the complete hemorrhoid now to the center, which can avoid damages of deeper layers like I told you. Now, as you can see in the beginning, might even frustrate you in the beginning, there is not such a big effect always. It depends really on the hemorrhoid. If it's a big pile, sometimes you need some time and some patience to see the changing of the color in the tissue. And then we do it in the first step at the area where we think the feeding artery is, around 10 seconds to be sure that there's enough heat. And then we can step by step, like it's shown here, change the position and go and put it to all the parts of the hemorrhoid, what we can see. Now you already can see on the tissue a changing of the color, it becomes a bit white, and there is no need to see a completely necrosis in this moment. Surgeons, I know, always want to see a mega effect when they do something, but it's for sure, believe me, here is effect, so this will be enough, what you can see now. When we take out the needle now, we will do a coagulation of the insertion point, which is quite nice because even when there's some bleeding in between, you can always use the needle first and try to make coagulation. Here you see now the coagulation point, and this only a few drops of blood are not very dangerous for us, so we are not in worry about this. Now we clean a bit and we for sure cool it down with this prepared cold gauze. By the way, it's not important that you need now ice water. I even recommend not to use too cold water because the patient, as you remember, is awake and ice water in the anal channel is not really comfortable. So it's enough when it's cold, like from the tap, for example, about 20 degrees, 80 degrees, much enough. Like I said, you can do now the spots on the surface, or as it's shown here, also you can do some lines. Most important is that you do some destroying of the superficial tissue because it might not be reached by your previous treatment. And after this, here you can see on very nicely the reaction and for sure necrotic area. So this is now one pile. Please take it out and insert it again. Never turn this kind of endoscope because the opening will cause that the hemorrhoid maybe will stick inside and it's very uncomfortable for the patient. So try to take it out and just put it back in the position what you need next. As you can see here also, in the beginning shown skin tag is now almost disappeared. For sure this effect will not last maybe forever, but sometimes really because of the shrinking effect, the skin tag itself also becomes smaller. So the same now, we will go forward now because it's the same as we have seen. And this was now fast in the 7 o'clock position. So what we have for recommendations for the patient afterwards. During our trial, we didn't give them anything mandatory. We just told them, if you need, take painkillers. We always recommended ibuprofen, like 400 milligrams a day, for example, 2 to 3 times. If you need some lidocaine ointment or something to as a stool softener. This was in the beginning as needed. Right now, we do this that we can tell the patient in the first 2 or 3 days, take it regularly, ibuprofen, because then you can even avoid maybe an edema and the maybe appearing pain anyway. So the trial is finished now, so we don't need to have this recommendation like we had before. Next. But the process is quite defined. It means in the first 24 hours we have a coagulating for sure. And after this, 1 to 3 days later, there starts a fibrosing, then a necrosing. And this is, I underline it, it's a necrosis of the hemorrhoidal tissue, not a necrosis of deeper layers. So the wall, especially the muscle and sphincter, are protected if you do exactly what we said, means lifting up the probe, put in the local anesthesia, pillow in the right position, then nothing can happen to the wall. After 14 days, we have an exfoliating of this necrotic tissue and the wound is formed, which is in the end a small scar, which has no further effect for the patient anymore, especially what we never saw is some kind of stenosis. Next. So this is a healing process, so it's a nice video. After about 2 to 3 weeks after the procedure, we put in now the endoscope. You see again for sure, this is interesting, what we will see soon, the mucosal prolapse inside, which is here first circular to see. But when we take it out step by step, and please pay attention to the area between 7 and 10 o'clock position, you will see now how the mucosa there is first of all smaller and there is a lack of this mucosal ring, and you see now a bit white tissue and for sure also the hemorrhoid which has been in this area disappeared. So when we take it step by step out, you can see very well in the rest of the ring the mucosal prolapse, but between 7 and 10 it's not anymore. So yes, we can also treat a mucosal prolapse in the same technique, because it happens anyway when you treat the hemorrhoid. So now we will see it better when we just take it out a step. I just try to clean everything and then see this a bit white tissue, but nothing more. And now you can see excellent difference from the left to the right side. Yeah, and for sure there was no prolapse. By the way, the prolapse effect, I mean the shrinking caused to an immediate effect. So we have immediate effect means shrinking and the disappearing of the prolapse. This happened at once, and in the next few days, patients always tells that the bleeding stops also very fast. So one of the symptoms which are very interesting, nice to treat by this treatment is bleeding, because this stops normally the next day, and the prolapse itself. As everybody knows, the problem is sometimes with symptoms like itching. This is always difficult, but bleeding and prolapse is perfectly treated by this technique. So here are just some examples before and after the treatment. You can see on the left side very big piles in maybe 1 to 3, in 4 to 5, and 6 to 7 o'clock position. And immediately after the treatment, there's only this white or dark red tissue, and now appears another hemorrhoid, which was not seen before in 12 o'clock position. It was hidden behind the other hemorrhoids and came up after we treated the rest. And for sure, we didn't treat all of it now, because we tried to do a tailored therapy, means what really suffers, or because of what the patient suffers, we treat first. And in this case, we treated these big piles which prolapsed and not the smaller one in 12 o'clock position. Next. Here also you see a fast effect, what I told you, this shrinking effect with this immediately effect of lifting, like an anal lifting. We see now here in 10 to 12 o'clock the hemorrhoid. Immediately after the Rafaelo procedure, it disappeared, it shrinked. And after 6 months, we can really only see this very small scar, 12 o'clock position, that's all. This is some other example, because this therapy is supposed to do in second, third degree, and also possible in fourth degree. But as everybody knows, if there are now big skin tag or really big prolapse, you might not be able to treat it with this technique. But with this smaller fourth degree hemorrhoid, like it's shown in this picture, because this was without pressing, we can also treat it. And 1 week after, also this one disappeared, and the necrotic tissue, this picture was about 10 days after procedure, and it became for sure smaller, was also only this small necrotic tissue area. Next. So it was a pleasure to tell you all of this technique stuff. I hope, because I used to speak very fast, I'm half Italian, I'm sorry about this, but this is my nature. I hope everybody gets all the informations. I will get now, or give the word to my colleague, Dr. Schäfer, who will tell you everything about our own trial and about our results. Enjoy.
Okay, thank you, Carlo. Thank you to be together with you, all the British experts tonight. And thank you also for the invitation from the side of FCARE. Our story with the device was a little bit a special one, because we began in 2015 and nobody knew something in this time period about this technique, and so we began with the first patients, and but we saw immediately some effects. Some good results. So we started to make a documentation of the first patients, and the first 101 we published in a German paper in German journal, and then we started a multi-center B-centric trial together with colleagues of Münster, which is somewhere in the north of Germany. And we tried to sample in this trial, prospective trial, 100 patients. The aim was to see how third-degree hemorrhoids in local anesthesia or in sedation using the radiofrequency ablation was able to make progress in their complaints. That means their restrictions in lives and their complaints regarding pain, bleeding, and so on. So next one. Like I told you, we treated 98 patients in this trial, 87 men and 11 women. And with one pile in 42 patients, and in 2 piles in 56 patients. All of them were third-degree piles. The follow-up was performed after 1 week, after 4 weeks, after 6 and 12, and lasted 24 months. That means 2 years. The patients were asked about the use of painkillers after the procedure, and about their complications, what they have, what had been their complaints, and their disability for work, and the daily use of painkiller. And then we used the proctological symptom score to document the itching and the pain and the bleeding and the weeping of the patient. Next one. This is the proctological symptom score, and 0 is the minimum. That means no complaints, and 10 was maximum complaints. That means, for example, for bleeding maximum, and the patient had to decide and give a sign on this panel. Next one. Now I give you the results about our trial. The patient demography was, we had a mean age of 48.7. Like I told you, male were 87 and 11 female. The BMI was medium 25.7, and 53 of the patients, they had previous treatments like ligature sclerotherapy. 4 of them had surgery like Milligan-Morgan procedure or others, and 12 of them were a redo operation after radiofrequency we made before. The medium energy per node was 3029, and what is important that we carried out this procedure in local anesthesia in 85% of the patients, and only in 15 people we made a sedation therapy. This is very important in our point of view, because we have, if we make local anesthesia in these patients, we can talk with them, and if the heat is too high, we can stop the procedure, cool down a little bit the situation, and then go forward. This is, in our point of view, very important to avoid damage of the muscle layer of the rectal wall. Next, please. Complications, like you saw, we have 19 complications, minor complications like mild bleeding and some temperature after the procedure, and diarrhea in 2 cases. One of them has much pain and swelling. Is also, like you know, anal vein thrombosis occurs here in our series in 3 patients, and 1 patient complained about increased urination activity after the procedure. Major complications were bleeding in 4 cases. That means the patients reported us that it had that the bleeding was very we had a bleeding which was normal, more than normal, and 2 of them were in the operation theater in 2 other hospitals, but they never found a bleeding source, so there was no intervention afterwards. We have an infected necrosis in 2 patients. We carried out also CT scans in our study to make to have more information about the deepness of the necrosis. That means we wouldn't have any abscess or some infection signs. And severe pains were documented by 2 patients, but after the treatment with painkillers, the patients suffered no more. So next, please. The pain after the procedure is documented here in the VAS score, you know it, and 33 of the patients, they suffered from no pain. They had no pain, and like you saw in this column, there was only these 2 patients with maximum pain, and the others were in between. Next one. The use of painkillers after the procedure is shown here in this figure, and you see that 2/3 of the patients didn't use any painkillers, and only 20%, nearly 20% used the painkillers for 3 days, and 17% more than 3 days. Next one. So these are the function, not the function, these are the results about the typical hemorrhoidal complaints like itching, pain, bleeding, wetness, and at least we reported the amount of the total scoring amount, and you see that it was statistically significant after 3 months, 6 months, 12 months, and 24 months. And the only thing which is to consider is that the bleeding after two years reoccurred in some patients. Next one, please. And now we have the documentation of the prolapsing hemorrhoids, which were per 100% at baseline, and what was also significantly reduced after 1, 6, 12, and 24 months. But you see also that that 20%, 1 of 5 patients had a recurrence of his prolapsed hemorrhoids after 2 years. So next one. If you compare these results with the results you have from Hubble study or for ETO study, you can see that after rubber band ligation, you have after 12 months reoccurrence of prolapsed hemorrhoids in nearly half of the patients. In Hull procedure, 1/3 has recurrence, and if you go to the ETO study, you see that 14 and 32 patients in the surgical excision therapy, Milligan Morgan, or stapler hemorrhoidectomy had recurrence of hemorrhoids. And in our study, after 1 year, we have 17% of recurrence. After 24 months, we don't have any data for the rubber band ligation and the Hull procedure, only for the surgical excision and the stapler hemorrhoidectomy in the ETO study. And you see that our 23% is in accordance with the other recurrence rates you see here. Okay, next one. Conclusion, I will tell you that radiofrequency ablation in our trial was quick, low in pain, safe, and effective. And it was now not only a short time follow-up, it's also a mid-time follow-up. That means after 2 years. And so the patients and the restrictions for the patients after this procedure are superior to the conventional treatment. And what is also important is that Rafaelo we can do it outside of an OR setting. That means we did all the interventions in our practice, and this is perhaps very important also in this period where we have the pandemic situation, and we can also treat them outside of the hospitals, and the recovered units are not burdened by hemorrhoid treatment. So this is everything I would like to give to you as information regarding our trial, and please give us your questions and we try to answer. Thank you very much.
Thank you very much. That was a well, fantastic piece of work with extremely assiduously followed up patients, and I'm sure there'll be lots of questions for you. We're going to reserve questions for our question and answer session, which we're going to do in the not too distant future. So before we get to that, I'm going to ask my friend and colleague Mohammed Adama to tell us about the experience that we had when we started doing this procedure in the UK. Mohammed, over to you.
Thank you very much. I'm just going to share the slides with you guys. So we actually started this procedure in the UK now almost 4 years ago. And when we started it and approved it, we did an audit to follow up patients and have their outcome. We published our data, if you want to go back to the paper, in the Journal of Techniques in Coloproctology. That was in 2019. I am going to present the data from that paper, which is actually promising for the procedure itself. In terms of methods, we've included actually all the patients, regardless of their hemorrhoidal grade. I want to highlight that more important is the hemorrhoidal severity score for those patients, which means not really the anatomy of their anal canal, but actually the symptoms they suffer from due to the hemorrhoids. And that will include, you know, bleeding, itchiness, discharge, and if there's any prolapsing element of the hemorrhoid. So these things can actually guide the treatment, and I think anyone above the hemorrhoid severity score of 7 is eligible for this procedure. Again, not to treat the anatomy, but to treat the symptoms. We had a patient questionnaire where the patients were asked about the pain score and so on, a satisfactory score, and recording any complications on day 1, day 3, and 8 weeks after the operation. We followed the patient up for up to 24 months. Before and after the procedure, we assessed the incontinence score, which is the Cleveland Clinic we used, and hemorrhoidal severity score before and after. Also their quality of life. We looked at their visual analog score and their famous EQ 5D5L system. This is the demographics of patients. So our kind of majority are male. The mean age was 46. And as you can see, we included all the grades. We had 9 patients with grade 4 hemorrhoid and 3 patients with grade 3 hemorrhoids, 10 patients with grade 3 hemorrhoids. We recorded all the intraoperative kind of details that we recognized as significant. This included the number of hemorrhoids that were treated. I saw a question from one of the participants asking how many you could do at one sitting. I think as long as you leave enough bridging between the areas you actually coagulate, you can do up to 3 hemorrhoids in one sittings. We were very careful because it was a new procedure, so we were quite conservative in terms of how many we treated at a time. As you can see, we mainly did 2 rather than 3. The energy applied per joule was 1,000 in average. The minimum was 150. This is per hemorrhoid. And the maximum joules you can apply that will appear in the machine. This is the energy you apply is 3,000 really, and this is a recommendation from the company that makes the device as well. Time per hemorrhoid we spent was about half a minute on average, so it doesn't take too long. Not more than 2 minutes per hemorrhoid was spent to actually fire the energy on a single hemorrhoid. The duration of the procedure itself was quite short, which is good for use of theatres. If you're doing it in theatre, it was only 10 minutes. By the way, we did these patients under sedation, and local anesthetic, but all of them were sedated, light sedation. In terms of pain score, that was quite impressive. Patients didn't really have much pain. As you can see, on day 3, they hardly had any pain. This is out of 10, so 0 out of 10 immediately after the procedure. We do actually put a perianal block for our patients, so that can explain that they had no pain after the operation straight away. But then on day 1, their pain score was also low. And day 3, 8 weeks later, they weren't on any painkillers, and the pain score there was no pain at all. In terms of return to work, we asked them, when did you feel that you were fit to go to work? And the mean was 3 days, with standard deviation of 1. We do give our patients a week or 2 of sick routinely after surgery, so it wasn't relevant to ask them when did they go to kind of work, but actually when did they feel that they're fit to do normal activities. The postoperative complications, we really had, the main complication was in 2 patients came back with bleeding, and that was about a week later. We feel that it is worth telling the patients that they might have minor bleeding after 1 week, and this is because the scab falls off after the coagulation and the necrosis we kind of cause, and that can cause a bit of bleeding. If the bleeding is worse than they would expect, more than minimal, then they should probably come to hospital and they should be advised to do so. We also recommend to avoid this procedure in anyone who's anticoagulated. If you are to do it for somebody who is on coagulation, you shouldn't really restart their coagulation for at least 2 weeks if you are going to do it. So stop it a week before, or if it's as per protocol, if it's warfarin, I think a week before, and then you don't restart it for 2 weeks after. You can't probably do that if patients have kind of a serious indication for the anticoagulation. But yeah, so we recommend to avoid applying it to anybody who's anticoagulated because they can come back with severe bleeding and require hospital admission, and you can struggle stopping that bleeding. In terms of recurrence, we followed the patients up in average of 20 months, and we had 4% recurrence rate. There was no really problems with incontinence. You know, although we are operating above the dentate line, you still have internal anal sphincter above that, and that can be damaged during the procedure. There are means to avoid that, as explained by my colleague, Dr. Vivaldi, when he explained the procedure. You know, lifting the mucosa up to and injecting the kind of local anesthetic or even saline to separate the mucosa from the muscle underneath. So it was important to assess patients' incontinence before and after. There was actually no significant difference at all. We looked at the hemorrhoid severity score. As I said, 7, anybody above hemorrhoid severity score of 7 should be offered the procedure, and this is their score afterwards, which was assessed 2 months later. So they do improve in terms of symptoms, as you can see. Visual analog score, so they all actually pointed out to a better quality of life afterwards. This was also assessed 2 months later after the procedure. And also their quality of life improves according to the EQ5D5L scoring system. In conclusion, we feel this is a safe procedure. It is, as long as it's used in the kind of well-selected group of patients, I think it's safe and has good outcome. We do need to compare it to other procedures to be able to speak about it against other procedures, but I think at this stage it's hard to conclude how good it is in compared to other procedures, because it needs a trial for that, I guess. I'll hand over to Professor Cohen. Thank you very much for listening.
Thank you, Mohammed. I think you have to remember that this was our initial early data, having sort of pioneered the technique in the UK. And as Mohammed said, we did them all because we were being extremely cautious at the time under heavy sedation. But as demonstrated by my colleagues, Dr. Schaefer and Dr. Valdi and others, it's very much possible to do this as a procedure with a patient awake with suitable local anesthesia. So I'm now going to hand over to Mr. Nastro, who's going to give us his experience of a considerable number of patients again, and look forward to hearing what his results showed us. Thank you.
Thank you, Richard, for the kind introduction, and thank you, Adam, for the invitation for this wonderful webinar. I just want to try not to repeat what my colleagues already said and the very good presentation done by Mohammed. I just want to briefly explain my experience, which, as you, I was very cautious when I started. I think this is the way to start a new procedure, in particular when you are in the learning curve. And I briefly want to talk how did we introduce this technique in my hospital. Initially, two of my colleagues, colorectal consultant colleagues who are not here now, Rakesh Bardwaj and Jay Kadamek, they went to Europe to observe a surgeon who performed this technique. When they returned to the UK, we read the evidence available, we watched some video, and then I attended a course at UCL with Professor Richard Cohen. And if you are based in the UK, I strongly recommend to attend this course. We decide to offer the first list to 3 selected patients with first-degree hemorrhoids, merely complaining of bleeding. We did with all 3 consultants in theater under general anesthesia, lithotomy position, because I think even if you're a colorectal surgeon and you offer advanced proctology procedure, there is always a learning curve, and it's important to be cautious and safe. I then felt comfortable to offer this procedure on my own, on my list, and I did the first few cases under general anesthesia. I then moved with the agreement of my anesthetic consultant to deep sedation on propofol on lithotomy position. After a few cases, we moved to the lateral position under propofol, and this was the first year where I believe I completed my learning curve. And in the last 2 years, I now offer this procedure under local anesthetic on the lateral position in the ambulatory setting. I only offer to some patients 2 milligrams of midazolam, just because I still offer this procedure in the main theater. And I think this causes a bit of anxiety to some patients. So I offer 2 milligrams of midazolam, the same sedation that we offer when we offer a colonoscopy without the assistance of the anesthetist. I was ready to, 6 months ago, to move the procedure in the ambulatory setting in the endoscopy unit, but unfortunately the COVID stopped everything. My experience, I published my experience, the preliminary experience, and I found very interesting now, after watching the Mohammed presentation, that we almost reproduce the same results. And I think this is quite interesting. I basically done a retrospective review between June 2018 and June 2019. Only patients operated under local anesthetic on the lateral position. There were 36 patients. And these are all patients that have been operated by myself after the learning curve. Of these 36 patients, we excluded some because they were lost at the follow-up. The follow-up, basically, I normally see these patients face-to-face after 3 weeks, face-to-face after 6 months, and a telephone follow-up after 1 year. Mainly the patients, 96% of these patients, they were complaining of bleeding. 20% of these patients were complaining of first or second degree prolapsing hemorrhoids. 7% of itching or discomfort, and 7% of soiling and discharge. We had a follow-up of medium follow-up of 3 months. Of these 36 patients, 73% had a complete resolution of the symptoms, and 27% they had some recurrent symptoms. I want to make it clear that the primary outcome of my experience was only to assess the safety, the feasibility of the technique, and the efficacy. I did not use an hemorrhoidal score like Professor Cohen, and my next step is to do a prospective study where I will use an hemorrhoidal score preoperatively and postoperatively. Of these 36 patients, I had some complications, and interesting, they were all in the first 3 months. I'm not sure if because it was still at the beginning of my experience. Of these 4 complications, one patient had a prostatitis. He never had any urinary symptoms, and since the day of surgery, first he started developing urinary frequency, and then he had the typical symptoms of prostatitis, which was treated by antibiotic, and it takes several weeks to settle. I had one patient that he developed a stenosis of the rectal mucosa, circumferential stenosis of rectal mucosa, which he was treated by myself under general anesthesia with a simple dilatation. He had a complete resolution of symptoms. And I had the 2 patients that they complain anal fissure. This was also in the first 6 months after the learning curve. Since then, since I'm offering this procedure now under local anesthetic in the lithotomy position, I had only one patient. He was readmitted 7 days post-op with bleeding. However, he was managed conservatively and did not require any further surgical intervention. I inject a local anesthetic, the lidocaine 1%, no more than that. And I advise the patients, I do not use any antibiotic, and I discharge the patients on analgesia. I just tell them to take some paracetamol if it's necessary. I never had any patients complaining of severe pain. I think all the rest, I don't want to repeat what is already been told by my colleagues, but of course I'll be happy to answer any questions.
Thank you, Piero. That was, again, a very useful presentation. I think, I mean, one of the messages that to take home is that, you know, when you start doing a procedure like this, it takes a little while to get the hang of it. So you need to start carefully, and then once you get an experience like our colleagues from Cologne, you know, you can become, you know, much more easy with no sedation, local anesthesia, when you get a real feel for the treatment. One of the things that I find when I do it is that you feel, as you're using the device, a contraction around the end of the Rafaelo probe, indicating that you're sort of, in my mind, sort of destroying the hemorrhoid and shriveling it up. The only other comments I make is that in the UK, we have something called a black spinal needle, which you can steal from your anesthetic colleagues, which is a perfect device. It must be very similar to the ones that our colleagues in Germany use. So ask for a long black spinal needle. It's always available. And the other thing to stress is this business of injecting a cushion or a pillow underneath the hemorrhoid to lift the hemorrhoid off the underlying internal sphincter, and not inject into the hemorrhoid itself. Because if you fill the hemorrhoid with liquid, the Rafaelo device is ineffective or less effective. So one has to get the hang of that. And as demonstrated beautifully on the video by my colleagues from Cologne, you can use the bevel of the proctoscope to lift the hemorrhoid away, lift the needle away from the underlying muscle. And I think most of the complications that I've heard from the tales today, we've seen. And the only thing you have to remember is that you see these if you do a traditional hemorrhoidectomy or a staple hemorrhoidectomy or a halo. All of these procedures are fraught with complications that we all see from time to time. And I've indeed seen life-threatening hemorrhage 10 days post rubber band ligation in a patient whose hemoglobin dropped to 2, but luckily we managed to save them. And indeed, a famous surgical colleague of ours had a similar issue when his hemorrhoids were banded. So you can't win. And even injection sclerotherapy, I've seen patients develop severe prostatitis if you accidentally inject into the prostate gland. So that there are hazards and complications to all types of hemorrhoid surgery, and I would put it to you all that this technique is another technique in our armory to treat hemorrhoids, and each surgeon will find his happiness about what hemorrhoids he's going to treat with which procedure. So I think what I'm going to do now is there are 176. Some people have obviously fallen asleep or fallen off. Maximum we were at 190 people on this webinar. So I'm going to go through and ask the questions that that our colleagues out there have asked, and put it to various of our colleagues here. So the first question comes from Srinivas Kalaskar. I apologize if I pronounce your name wrong, and I'm going to put that to Dr. Schaefer, and it said, when you use your injection with lignocaine, do you use it with adrenaline or plain? And do you think using adrenaline in the lignocaine is a good idea? Dr. Schaefer.
Yes, I'm here. Could you repeat the injection of the?
So the solution that you use for your procedure, do you use lidocaine with adrenaline or without adrenaline? And do you think actually using adrenaline would be a good idea?
Yes, we use it without adrenaline, and but it's always a good idea to have also adrenaline inside. Like this is the traditional form to avoid bleeding. But we didn't have any bleeding after the injection, so it's also good without.
Thank you very much. I also noted on your video that you cunningly use the hole that you put the injection in as the same hole in which you put we
use the same
probe,
hole,
which is I think that's quite a good tip. So moving down the questions, Anne already has asked, how often do you trigger a hematoma when infiltrating the local anaesthetic? So I'm going to ask Dr. Vivaldi that. How often do you get an annoying hematoma blowing up underneath the hemorrhoid when you do the injection?
Well, thank you, Professor Cohen. As I told you during the procedure, during my presentation, if you are fast and then the probe is already prepared, you've given the tissue any chance to develop hemorrhoid or any kind of hematoma. So just be fast. For sure, it can happen, and you see it, and I think it doesn't happen very often. I think in all these cases, I might have 3 or 4 times that it's really an annoying size. And sometimes once I had it, that it really makes it impossible to do the procedure afterwards because you come so fast up that you cannot do anything anymore. This happened very seldom. But I learned when you really use the probe immediately, you can really try to avoid this.
Yeah, no, I think as described by our colleague, you can get the hematoma from the injection, then you have to pop the old magic finger in and press on it and hope that it settles such that you continue, or indeed quickly apply the device. Just to answer the next question from that famous anonymous attendee, how many piles can you get in one go in our views? And we've already alluded to that. And I think a lot of that depends on how accustomed you are to the procedure and how brave you become. So the thing you have to bear in mind is that if you fry the entire anal canal in one setting, you may cause stenosis or narrowing or other problems. So initially, most people start by doing 1 or maybe 1.5 hemorrhoids at a time, and then as you become bolder and more used to the procedure, you can do more. So I think most people would probably do a maximum of 3 in one go. I'll just check. Dr. Schaefer, how do you feel about that? Is that a reasonable answer?
Yes, you are right. This is the way how we do it. If you are in the learning curve, not more than 2 hemorrhoids in one session. And if you are familiar with this technique, you can proceed to 3 nodes. But the problem afterwards is like in rubber band ligation or other procedures, you have more pain, more bleeding, and so on. So better to divide, if you have surrounding circular hemorrhoids, to divide 2 sessions, and the patient will be satisfied with your your procedure.
Yeah, I think that the concept of bringing a patient back, particularly if you're able to do it under local anaesthetic for a second or third treatment, is extremely
Never
reasonable.
a problem to do it,
I know there are costs involved, but I think you have to do what's right for the patient. Now, the next question is from Io Ashoa, who I know well. Nice to see you, Io, on the call. And he comes up with actually not a bad idea. Is should we be using a local anaesthetic type preparation as lubricant for the anoscope, a bit like putting EMLA cream on a patient's hand before you pop the cannula in? Piero, what do you think about that? Is that a good idea? So should we be thinking about that?
I use this at the end of the procedure. The local anesthetic normally is in the UK is in the syringe that we use when we insert the Foley catheter. At the end of the procedure, I just leave in the anal canal, and then I do a gentle digital examination to be sure that they go all around the anal canal. If this eases the pain, I'm not sure, but I've been using this now for the last 1.5 years.
I mean, I think it's quite a good question, and maybe we should be popping EMLA cream around the proctoscope because it lasts for quite some time afterwards. The next question, there's the second and third aspects from Saman Taha is we've talked about recurrence rates compared to other procedures, and we've also talked about the number of hemorrhoids you can do in one session. Most of us probably wouldn't do more than 3 in one session. But the first question there, which I'm going to put to Dr. Schaffer, because he showed us so beautifully how he uses the wand to put it directly into the hole he's made with the needle for injection. Where exactly do you aim to put the probe in? And you talked, Dr. Schaffer, a bit about, well, I'm trying to hit the feeding vessel, which is a bit of a Halo-esque, THD-esque concept. So how have you got any idea where the feeding vessel is, if I may ask? And is it just experience that you really know where to put the probe? Over to you, Dr. Schaffer. Was it Dr. Schaffer?
Yeah. What we do is a very standardized procedure. We go forward with the needle from the hole 1.5 centimeters deep inside the hemorrhoid, and then we go to the right and make the first radiotherapy, and then we go to the left, make the second one, and then we draw back the catheter and make 2 other radiotherapies to the right and the other one to the left. That means 4 times in 4 directions. And if we touch the vessel, which is responsible or which is the nutrition for the hemorrhoid, we don't know. So we have no studies about ultrasound studies or so, Doppler sound, and to see what happened afterwards. This is an issue for the next trial to see what happens with the vessel.
Thank you. If I can ask Dr. Valdi, so as I'm comparing, I get the chance to ask questions I would like. The 2 main complications that I've come across, both myself and in listening to colleagues who've gone out into the community to do the procedure, are one gets the odd patient who has terrible anal pain afterwards. I mean, excruciating pain. You end up having to speak to them every other day to reassure them it will get better, and it takes several weeks before it gets better. My first question to you is, what do you think is the cause of that? Is it because the surgeon has put the probe in the wrong place? I'm not sure that is true. And is there any tips to help a patient like that? So one of your patients comes back in excruciating severe anal pain. Do you MRI them? Do you EUA them? Do you just reassure them? How do you deal with that patient? Dr. Vival?
Well, we had once in the very beginning, one case where a woman we treated first time, I think it was our patient number 3, We treated her, and she had exactly this. She had really a very severe pain. And we was for sure worried about this because we was not sure a new procedure, did we do anything wrong? Is there any serious problem? Maybe an abscess or something, I don't know, infection of the pelvis or whatever. So we performed the CT and checked everything what we can see, but we couldn't find anything. There was, like always in CT after treatment, a little swelling in the anal channel, but there was no abscess and no anything other problems that could cause this problem. So in the end, we just figured out that some patients, maybe in this procedure, we really didn't respect at all the dental line. Maybe we came too deep in the area of the dental line by the needle. But when it's done, it's done. So you cannot change anything afterwards. So we have to handle it. And what we did then, in this case, we just added on the ibuprofen some, what is in German common, Novalgine as a second line painkiller, and it was already enough. So just after 3 days, she was happy. 4 days later, she could fly even to New York, where she had an appointment. So this was to handle. But the case, thanks God, of really not handle pain, which was not to handle, we didn't happen all this time. I think if you really respect the dental line, if you really check out where you are, and for sure this is easier local anesthesia because they have the feedback of the patient, you can avoid really difficult damages.
Piero, have you had that experience of anyone with disturbing, worrying pain post-procedure?
Yeah, interesting. I had 2 patients with severe pain. They were all in my preliminary experience when I was still doing under GA. And when I examined these patients, I found both of them what I call not really a typical fissure, but more fissuration. And I think this happened because the patient was under general anesthesia. I was still in my learning curve, and I went a bit too low. And again, I think this is an advantage of doing this procedure under local anesthesia, because you know exactly if you are too low or not. I had some patients, for example, quite interesting. We know that if we go above the dental line, the patient should not feel any pain. But I note in some patients, even if you do the first injection, I use exactly the same needle that you mentioned before, the spinal black needle. Even if you go above the dental line, there are some patients that can still feel injection of the needle. And I think if you offer this procedure under general anesthesia, in this patient, you may go too low and you may cause a fissuration of the mucosa of the epithelium of the anal canal. So both cases of severe pain, this is what I found. Since I do under local anesthesia, I never experienced any pain, any patient with severe pain.
No, that's great. And I have to say that we have many patients who come back who had no pain at all. And if they have a subsequent hemorrhoid, they ask to have the same procedure done again. We've got quite a batch of those in our practice. Just to carry on with that. So the next question from Anne already is persistent ulcer, is that an issue? And I'm going to combine that with what do you do with a patient who comes in on day 10 with severe profuse bleeding? And I'm going to ask Mohammed, I hope you don't mind, Mohammed, if you can talk to that. So persistent ulceration as a result of the necrosis caused by the device, and how do you deal with it with a big bleed that comes in 10 days later?
Well, I think patients have to be assessed for, the blood loss and how severe is that. We had patients who come with severe bleeding. So initially, obviously, resuscitation and correcting the blood loss by blood transfusion. And then there is a room of taking them to theatre and doing an EUA because it is low in the rectum, and you could actually do hemostasis in that way. If that fails, at UCLH, there is the alternative procedure to treating hemorrhoids, actually even electively, which is to, by IR, ligate the superior rectal artery. Which
I don't think we've had one that we've had to use IR for, though. After this procedure, though, I have seen the use of IR in severe post hemorrhoidectomy bleeding in patients who have other odd issues. I think we've not had to take anyone back to theatre, but we've had to transfuse a couple of patients, haven't we, over the last few years?
Yeah, they usually settle with initial resuscitation, but sometimes if the coagulation, if the patients are anticoagulated, this is always a trouble. And as I said, we try and avoid doing it in these patients, but obviously you need to correct that and treat it like a PR bleeding. Most of them do settle. If they don't, initial management will be transfusion and probably other means to stop the bleeding. To then follow up on the ulcer, I think you just have to make sure it didn't cause a fistula and so on, and therefore further MRI and things like that to investigate this would be appropriate, I guess.
So just moving down the questions, is it possible to apply the RF energy on the surface of the piles without the need to puncture it? The answer is we do touch the probe on the surface of the hemorrhoids once we've done the use of the probe within the hemorrhoid. I think just touching the surface doesn't quite do the trick. I'm sure my colleagues would agree with that. If secondary bleeding is not stopped, secondary bleeding, as we've just discussed, normally it does stop, but you can do an EUA with a view to putting a stitch in if required. I've not had to do that. I'll ask my colleagues in a moment whether they've had to too. And another good question here. So Haydar Aslam asked, Dr. Piero brought the subject up. You get a patient with an anal fissure post RF ablation, as you can indeed after traditional or other hemorrhoid procedures. How do you treat the fissure? Piero, over to you.
Well, again, the two patients that I had, I will not say they had the typical chronic anal fissure. They had a fissuration, and I treat them basically with a topical treatment, local anesthetic gel, and some diltiazem cream. However, I noted that basically the pain settled after probably 2 and 3 weeks once the fissure healed. So I think it's just a matter of time. You need to reassure the patients, give analgesia, treating symptoms, and wait, and then it will heal.
Have you ever had to do Botox or worse to treat a fissure post procedure?
No, not in these cases. And regarding the bleeding, if I can just add something, I had one patient, as I said, which she was admitted, and I was very close to do an examination under anesthesia. I have the bleeding stopped, and I do not perform this procedure if the patient is on anticoagulant, only if he's on aspirin. I'm happy to do. But any other anticoagulation, I stop the anticoagulation according to the trust policy.
Thank you. There's another question here about the use of aspirin. We normally, but our patients are on 75 milligrams of aspirin in the UK if they're on that sort of the dose to stop coagulopathy. I stop it the day before. I don't have a big problem with aspirin. I don't like clopidogrel. So if patients are on Plavix or clopidogrel or the antiplatelet, those antiplatelet agents, I would be more wary about that. Dave Smith asks, in a patient with circumferential hemorrhoids, how does Rafaelo compare to other more major treatments? And if you're going to do 2 treatments, what's the length of time between each treatment? I'm going to put that to Dr. Schaefer. So the question is, have you done major hemorrhoids that would normally be treated with something like a staple hemorrhoidectomy? And if you're going to do 2 sets of Rafaelos, what's the minimum time between them?
4 weeks.
And what's your view on treating massive hemorrhoids with Rafaelo?
We tried to also to treat them, the circular anal prolapse hemorrhoids, and we had success in all the cases we made, because we made 2 sessions, and they were satisfied afterwards. But we need more time for it. That means the recurrence rates after 5 years or so, they would give us more information about this.
Great, thank you. There's a question about the payment system, which I'll leave to be answered by the team afterwards, if I may. Here's Michael Marfan from Australia. Yeah, nice to speak to someone. Wow, that's I don't know what the time is where you are, but I hope it's probably quite early in the morning, isn't it? And you asked, do we use pudendal nerve blocks as an adjunct to the procedure? And the answer is, personally, I do. I'm a great fan of blocking the anal canal for these procedures. but the difference is I do that under heavy sedation. I'm not sure how happy I'd be to do a pudendal nerve block in a patient who's on their side, and I'd probably use the technique shown so beautifully by Dr. Schaefer and his colleague Dr. Vivaldi. So pudendal nerve blocks, yes, I'm a great fan, but I think they need to be sedated for that. Here's a good question. So I'm going to put this to Dr. Vivaldi. What number do you consider to be the learning curve? How many procedures do you need to do before you consider yourself to be an amateur, a good, and an expert?
Well, I think, first of all, as the colleague Peronastro said, you have to be very careful in the beginning and just to be sure that you don't overdo it. And I think it's maybe not a bad idea to start, even if you don't have the effect of the local anesthesia and the feedback of the patient, maybe it's a good idea to start even in the beginning in general anesthesia, because then you're more sure, you can take your time, you can see exactly where you are, and it's for sure a bit stressful if the patient is also awake, because you have to be fast in this case because he feels everything, and you cannot do a half-hour procedure with an awake patient when you have the endoscope inside. If he's in general anesthesia, for sure it's more easy. So at the beginning, I think the first 10 cases, maybe you should do maybe even with general anesthesia, and then you can try to do it on the local if you are really already experienced in the proctoscopy at all. Because this is at all not a procedure, I think, for a surgeon who starts even with proctology. So this should be at all, first of the beginning, it should be someone who is experienced in proctology itself. And then after 10 procedures, maybe go to the local. And after another 10 to 15, I think you know what you're doing. So I think the amount is about 20 to 25 procedures which you need to know what you're doing there.
Great. Thank you very much for that succinct answer. We've got a question here saying, if we were going to construct a randomized comparison, which established therapy would we compare it to? I think that's a very good question. And judging by the results we've been shown tonight, I think you'd have to compare it with all the techniques. So you'd have to compare it with the halo type procedure, or HAL-RA, and against Miller-Morgan and staple hemorrhoidectomy. It'd be nice to do a trial randomizing between all of those techniques. And I think our colleague, I'm not sure if Dr. Brown, maybe Adam can comment what he's got planned as being the various arms of his trial. Bettina Best, you're asking whether a patient who's had recurrence of hemorrhoids after staple hemorrhoidectomy, have anyone here got experience of treatment using Rafaelo post staple hemorrhoidectomy? Dr. Vivaldi, please tell us.
Yeah, well, in the beginning, this is, by the way, let's just talk about the contradictions, because we said nothing about when you're allowed to do it. One was said that it's not a good idea to do it under full anticoagulation, for sure. As we accept aspirin as well. In Germany, it's 100 milligram a day, what you normally use, but we don't stop it usually. But what we do stop for sure is platelet anticoagulation. But the Rafaelo, in the beginning, it was suggested by the company that you don't do it when they have been done before staple hemorrhoidectomy, because they was afraid that there might be some interference with the metal clamps inside, or they have some heat feelings or whatever. So it occurs now what we did about 10 or 12 cases now already when there was already staple before, and we had at all no problems. The patient didn't feel anything heat more, and you could do it easily. So my answer is yes. You can do it, and there is no, you don't have to be afraid because of the metal which might be inside. Only thing what I recommend, as usual, don't do it earlier than 1 year after the procedure, because this, I think, needs time, and the metal clamp which are already in the surface of the mucosa should not be there anymore. They should be normally remove themselves. So I think a year after procedure, then you can do it.
Thank you. Question from Mr. Roy. What is the ideal interval between 2 sessions? And we've already said that we think about 4 weeks. We would say 4 to 6 weeks post from one session to the other. So I think that we've already answered that one. Here's a good question from Syed Hamdani is when do you stop? So you got your foot on the pedal and you're frying the hemorrhoid with a device. When do you stop? So I'll give you my answer and then I'll refer to my colleagues. As I say, you feel the hemorrhoid shrinking around you, and eventually you get a feel for it as to when you should stop, and the whole area blanches as long as you haven't injected liquid into the hemorrhoid itself, in which case it doesn't do that. So I think that comes with experience. That's quite a difficult question. Dr. Schaefer, when do you stop? Can you describe it to us?
It's a little bit like you mentioned it now. We have to have a look to the size of the hemorrhoid, and you have to be aware about the position. If you are very near to the anal channel, to the linea dentata, you have to stop. And what we have in our cases, we can speak with the patients, and if he gives us a sign that the heat is too much for him, we stop the procedure. This is the main sign for us to stop for a while and then go on if we say, okay, now there's no more heat. This is everything about this issue.
So out with the patient screaming for you to stop. In terms of, in your ideal world, when you're doing the procedure, what giveaways do you have in your experience of doing the procedure, in the feel and with a look, that makes you think, I've finished this one, I move on to the next one?
I have the volume of the hemorrhoid, and I have also the feedback how many joule I've given to the hemorrhoid. And if it's a large one, I stop after 3,000.
Okay, great.
A small one, it's like 1,500. And you have to make your work somewhere in between. And this is something you have in your learning curve.
It comes with experience.
Yeah,
I agree.
Mm.
So that answers the question about how long do you leave the generator active in every position. Additional local anesthesia to the intersphincteric space. I've never seen that as a particularly useful thing to do necessarily. And in fact, the injection, as shown, is very much just above the sphincter, to lift the hemorrhoid up off the muscle. Anal blocks we've talked about, and I've got a question here from Manos saying 4th degree hemorrhoids seem to be resistant to minimally invasive techniques with high recurrence rates when compared to traditional hemorrhoidectomy. So the question to you all again, which we've had before, is in someone who's got great big, juicy, prolapsing hemorrhoids, do you do Rafaelo, or do you just say, sorry, we need to do something more effective? I have to say that in my own personal hands, if I see a patient with hemorrhoids coming down to the back of their knees, I do some form of traditional procedure, and I like staple hemorrhoidectomy. We can argue backwards and forwards about that, but I normally consent patients for either traditional or staple hemorrhoidectomy, and I make the final decision when they're up in the stirrups. So let's take some views from around. I'll start with Piero. And what's your view on very large hemorrhoids? Do you do Rafaelo, or do you go straight for something more sort of vigorous?
No, the fact that basically I was very keen to introduce this technique in the ambulatory setting. I select the patient mainly with the bleeding symptoms and with prolapse no more than 1st to 2nd degrees. So if the patient has a large 3rd to 4th degree prolapse, so the prolapse is the main complaint, I do not offer this procedure. However, I've done some cases where I think they were not properly selected, where during the procedure I noted that the hemorrhoids were slightly larger than what I was happy to do, but I don't have enough experience to say if you work in a big prolapse or not. And in the 4th degree, I fully agree with you, Richard. Patient with the 4th degree hemorrhoids, I do not offer a minimally invasive treatment, and I inform the patients that I do an examination under anesthesia, and then decide during the procedure if I do Milligan and Morgan or PPH, or I can do a THD with mucopexy. And I consent for all these 3 procedures, and then I make the decision during the operation.
So that sounds very, very sensible. Dr. Vivaldi, what's your view on the patient with huge hemorrhoids?
Well, as we always also do still sometimes a state periodactomy, but to be honest, since we do the Rafaelo, we do it less and less, and the last years it was very seldom. I think you have to guide the patient, because I always say there is not only one possibility to treat hemorrhoids. For sure, you have to have a bunch of therapy techniques which you are able to do, and this is one of it. But when you talk to the patient and you see and hear what he wants, and you give him the option now to have a therapy in local anesthesia, I'm talking now about a third-degree hemorrhoids, not fourth degree. I said in my speech already that the big fourth-degree piles, it's also I would not recommend to do with this technique. But the third hemorrhoids, which are prolapsing, even if they are circle, you can talk to the patient. Some patients, they give the decision to you because they tell them, if there is a possibility in local anesthesia, I would love to do it and would love to try it, because it's easy, applicable, and you can do it even a second time very easily. If they are very scared and they say, no, local anesthesia is nothing for me, I would love to have a procedure which is done in one time, then for sure it's more easily to do in a circular situation than to a stapler hemorrhoidectomy. But these are the options what you have, and this is what you have to discuss to the patient, because I think it's very important that in these cases, more or less the patient can do the decision with you and not you for him. So this is what you have. Do it, and you can do it. And to answer Nestor's question, yes, we had circular prolapses, and we treated it by this, sometimes even in 3 sessions if the patient was very scared, and it worked for sure. And as Professor Cohen already said, it's a costly thing then for sure, but the patient is king in the end, and when he wants this, and we can do it, we can perform it.
Thank you. Quick question, do we give antibiotics post-procedure? And the answer is, what we tend to do is give a single shot of antibiotics at induction as a sort of prophylactic type thing. I suspect there's no correct answer to that. There was some studies in the past about the use of metronidazole post-traditional hemorrhoidectomy as reducing pain, but I don't think there's particularly a role for I'm not sure my colleagues are going to nod their heads that none of us give antibiotics post-procedure out with a patient who's got some extraordinary reason for having them. We've talked about having experience of doing RFA after other procedures. I think it's a very reasonable thing to do, and we've suggested 4 to 6 weeks between sessions. Have we had any? Here's a good question. Have we had any equipment-related technical issues during the procedure? I've had one when the machine didn't work and we just got another machine, but I've not had an intra-operative technical issue. Piero, have you seen that? I have not seen that.
No, I never had any of this problem. However, if there is only one thing I want to say regarding this, if you start, it's very, very important that your staff in theater is full trained, because they have to be confident of knowing how the machine uses. Because the last thing that you want, in particular, if the patient is awake, is having a scrub nurse or a circulator in theater that is not confident or he doesn't know how to use the machine. I'm lucky that the staff has been properly trained by the company, and I have to say I never had any technical issue.
Dr. Valdi, Dr. Schaefer, any issues with the machine during process? As I say, I haven't, apart from the one time when the machine itself didn't work, which we knew about before we started.
I don't remember any problems, because
No.
The staff is familiar with everything, and the only thing I had one time in Russia, I can tell you about this, because we had Congress in Russia, and I went there, and they had another machine, and the problem was that the probe didn't fit with the machine they had. So this has to come together, but this is the problem of the distributor, and this is the only problem we had.
Yeah, I think you just need to check that the bits all fit together and it works. Works, sort of thing. So another question here. Sorry, Dr. Valdi, excuse me.
Sorry, I just wanted to answer also that I never had any technical issues during the procedure. It went doses very well. I didn't have any problems.
Okay, that's great. Here's a good question. So when would you abandon the procedure and decide to do something else? I think the answer to that is if you find something that you weren't expecting. So if the patient turns out to have a full thickness rectal prolapse or some underlying malignancy, you abandon it if you find something that you totally weren't expecting. And I suppose if the hemorrhoids are substantially bigger than you thought, and you're in your learning curve, and you don't want to try it on something too bad. Yeah, I think that's, you know, it's only when you find something extraordinary. Is it safe to do? Here's a good question. So can you do, from Atif Alvi, can you do a combo procedure? Can you take the tags off and do a Rafaelo to the internal hemorrhoids? I'm going to put that to Dr. Schaefer.
This is not a problem. You can do it. If you a combined thing, like to excise the tags away and to make the inner hemorrhoid with Rafaelo, this is a perfect thing.
Okay, I mean, I have to say that I think I mean, it's obviously more difficult to do in the patient in the awake setting to take the skin bits off.
Yeah.
But I think in a patient who's heavily sedated, that's not an unreasonable thing to do. Yeah, that was a very good question. That's the last of the questions I've got. One question's disappeared. I didn't know you could take a question off, but there you go. I think actually we've covered quite a considerable area in terms of your questions about Rafaelo. Please do feel free to see has anyone got any more questions they'd like to ask us. I think this has been a really excellent session, talking about the use of this technique, which is another weapon in our armamentarium for treating this condition, which when many patients find quite an affliction. So I'm going to go around our team now, and unless you've got any more questions, and ask some comments. So start with Dr. Piero. Any last comments on the technique?
The only thing I want to add in the last question, if we can offer Rafaelo together with another technique. I've done in a couple of cases at the beginning when I was offering under general anesthesia. It's the only way, of course. But it's very important that you address the patient expectation. And I did a case where I excise a single hemorrhoid and a larger skin tags, and then I treat the other hemorrhoids with Rafaelo. And of course, the patient, he had quite significant postoperative pain, which was caused by the single hemorrhoidectomy. And the patient was quite upset because she was expecting to have no pain, because she thought that the Rafaelo was a minimally invasive procedure without pain. So it's very important that you explain this to the patients if you're offering a combined procedure. But now that I offer in ambulatory setting and the local, no, I do not offer any combined procedure.
Thank you, Piero. Dr. Vivaldi, any comments you'd like to make from this evening's presentations, including your own?
Sure. I agree absolutely with colleague Nastro, because you will lose the effect of the local anesthesia, and this very nice effect that is almost a painless thing, and you have to explain them that the skin for sure is very, very sensitive, and this is not the sham, so there is a difference for sure. So when you combine it, make sure that they understand that it will lose the effect of the painless procedure. This is true. I did some notice, by the way, during this webinar, which I loved, by the way. I think is really effective, and I think even now to all my colleagues, because this was really interesting. Even for me, I learned a lot now in this situation. I just want to say two things what I have to underline, because in the data even we presented in our own trial, maybe it is a bit misunderstanding, because we talked about 24% of recurrency of the prolapse after 2 years. So yeah, I think it's always difficult in hemorrhoids because there's no really complete good definition of what is a recurrency of hemorrhoids. Is it the symptom of the patient, means he has a bleeding, a itching or whatever, or is it really documented recurrency, a new hemorrhoid in the same already treated position? And this is always very difficult, and in all trials where you can see it's never really good defined what is the recurrency. But what I can say from my experience, in the same position after procedure, we saw really in very rare cases, again, prolapse or hemorrhoid. The patient for sure suffers again of problems, but it can be, when we, for example, treated 3 and 7 o'clock, that in the 11 o'clock position, after 2 years, he might develop another hemorrhoid. This can cause the symptoms. So it's difficult to see, and you have always to check if it's really recurrency or it's new hemorrhoid which just causes again problems. This is what I wanted to underline. And the last thing what I want to say is about the repeat. If you have to, for example, this is often questioned, if you can repeat the session, and if yes, how often, because we have here another serious effect at the end. I showed you after the procedure, these little scars. So this is something what I think what you can really easily do in opposite to the stapler, which you cannot do a million times. Maybe you can do it a second time if it's necessary, but this might even be difficult. But here, whenever you have a problem, again, because it is so fast and applicable and needs 10 minutes, as colleague Mohammed Edama said to us, which is also our experience, you can do it very easily again. And I think there is not even a limit of the redo for this procedure.
I think you're absolutely right. So I tell my patients that when I'm doing excisional hemorrhoidectomy that I'll take some of the hemorrhoids out, but the other ones might grow and they may notice them as time goes on later on. And I think unless you get very accurate photographs up a proctoscope, it's very difficult to tell whether it's recurrence of the hemorrhoid that you've partially destroyed or whether it's a brother or sister from just around the corner that's popping its head out. So I think that's a very valid comment. Thank you very much for that. Mohammed, any comments from Mohammed, last comments?
Thank you very much. I think my only comment is about the selection and to always kind of use the hemorrhoid severity score in the clinic. I actually used to show it to the patients and kind of score them then. It is published on our paper, so you can go back to it. It's very easy to follow. And anyone above hemorrhoid severity score of 7 is actually eligible. I think anatomically, you're not aiming to change the anatomy of the anal canal, but only the symptoms. So use the score for symptomatic treatment rather than changing the anatomy.
Thank you. Dr. Schaefer, any last comments from you?
Yes, my last comment is that we all together have shown that the Rafaelo is a safe, effective method for also prolapsing hemorrhoids. This is what we concluded in our study, but now it's time to compare it with the other methods like surgical excision, PPH, and so on. This is what we have to do in the future.
Yeah, I agree with you. I think it would be nice to have a study. The problem with these studies and with some of the ones that you alluded to in your paper is that one of them had 30 different surgeons doing the procedure in different hospitals around the UK, and you know, to get uniformity as to how the procedures are done in each case is very difficult. So and I think one man's 4th degree hemorrhoids is another man's 1st degree hemorrhoids, and how do you account for all of that? And I'm sure that those features could be looked at, and you could insist that only one well-known surgeon in each centre took part in the trial to make it fairer. But I think you're absolutely right, Dr. Schaefer. The only way to really know what is to do a trial. And then the other problem is, of course, everyone is different. Every patient is different, and every situation is different. And what you or I would use for one configuration of hemorrhoids, we wouldn't use for another. So I think these trials are difficult to construct, as was alluded to by one of our kind guests there. So I think that is the way future. I thought I'd leave the last comments to our kind host, Mr. Rubins, and maybe Mr. Pierre as well. Is there anything you'd like to add before we wind up tonight's excellent webinar?
Thank you. What I would like to say is that if COVID has created anything of a positive nature, it's the prevalence of forums such as this, which allows what we had tonight, an extraordinary presentation, combined presentation by an extraordinary panel to an extraordinary number of people at the same time. So much more is learnt by this sort of medium than by any smaller groups that we could get together. And I wanted to thank all individually and collectively for the effort and time you put into this. And I hope that the attendees have enjoyed it and benefited from this as much as we have. As far as the attendees that are from the UK are concerned, we know who you are. If you have any other questions, we'll be delighted to answer them. Everyone will be receiving link to this full recording. So if you didn't manage to see it all, it will be coming to you. And we'll follow up with each and every one of you after the presentation over the next few days. So await the email. But in the meantime, thank you all very, very much for your attending, and thank you to the panelists for doing such a marvelous job. Thank you.
Michael, Pierre, anything you want to
No,
like to add?
Same as Adam. I want to thank everybody, the participants and also the attendees all over the world. As you could see, there are some people from Australia who woke up early to attend this meeting, so everybody is really excited. No, I want to thank everybody for showing their interest. Thank you.
Great. And I too would like to thank my my colleagues for presenting their honest, really honest, excellent data. And I think this is the way forward in terms of how we bring new techniques into our practices. So thank you very much, everybody. I believe we're supposed to finish at 8 o'clock, so I'm going to give you all back 10 minutes of your lives. So thank you all for joining us, and hopefully we'll see you again at another webinar soon. Good night. Thank you.
Good night. Bye.
Thank you. Bye-bye.